Hi everyone, and welcome to this walkthrough of my machine learning project, where I explored the relationship between reproductive healthcare policy and maternal health outcomes. I was inspired to complete this project by the 2022 United States Supreme Court decision that overturned Roe v. Wade and made it possible for individual states to ban abortion. In the wake of that decision, many states in the country did move to pass total or partial bans on abortion and even criminalize abortion in certain circumstances, whereas a different cadre of states went the opposite direction and actually enshrined abortion rights in their state constitutions or legal codes. My goal was to move past political rhetoric and my own internal biases about the issue and look just strictly at the numbers to see if we could draw a clear conclusion on whether a state's legal restrictions on reproductive health care are fundamentally connected to the physical well-being of its citizens and specifically its mothers. To do this, I leveraged several different data sources, including emergency room visits from the CDC, historical data on rates of pregnancy, birth, abortion, and miscarriage in the United States going back to the 1970s, birth records from the CDC, data from the Health of Women and Children report by America's Health Rankings, and healthcare policy data from Law Atlas that tracks different restrictions or protections for abortion. As I move through the rest of the presentation, you'll see that the mathematical conclusion of basically every single model was absolute, and that is that a state's legal restrictions on reproductive rights are completely inseparable from its health outcomes for mothers. So with that said, we'll dive into the data. First, I wanted to see about how historical trends led us to today. So we looked at if 48 years of national trends in pregnancy, birth, abortion, and miscarriage rates fluctuated randomly, or if they followed structured historical patterns. To test this, we fed the data into an unsupervised k-means clustering model, intentionally hiding the year column from the algorithm. As you can see from this visual, the model perfectly partitioned the last 5 decades into 4 completely consecutive, unbroken chronological eras. It correctly isolated the post-Roe era of the mid-70s, transitioned into a massive stabilization era around the 1992 Casey decision, moved into a contraceptive era where long-acting birth control drove down unintended pregnancies and teen pregnancies, and finally terminated in the highly restrictive targeted regulation of abortion providers, or TRAP, law era leading up to 2020. And what this clean cluster separation proves mathematically is that national health behaviors adjust dynamically to macro level legal shifts. So Supreme Court decisions and state legislative frameworks are not isolated legal events or high scholarly debates. They actually are the primary systemic forces that carve out public health trends across the country and across generations. Next, I moved on to modern geography. An important technical distinction here is that the unsupervised clustering models on this page were trained strictly on underlying health infrastructure metrics, so things like maternal mortality rates, the prevalence of maternity care deserts, and doctor-to-patient ratios, and the models had absolutely zero access to state policy laws. Despite that, look at how the clusters map out spatially across the United States. The low-risk clusters in blue are closely aligned with legally protected regions in the Northeast and in the West. These states are defined by strong healthcare ecosystems with good outcomes for mothers. In contrast, the high-risk and moderate-risk clusters in red and orange are more concentrated in the South and the Midwest, and these are characterized by severe care deserts and high maternal mortality, which aligns with stereotypical political lines in the country. And these healthcare disparities themselves, as we discussed, are the spatial footprint of the legal landscape. One of my goals was to determine whether national clinical risk factors and complications could be compressed into a unified maternal clinical risk profile. And then I wanted to see how that profile varied across racial and age demographics nationally. What I found was that it is infeasible to create a unified maternal risk profile. Instead, clinical pathologies compound. Things like preeclampsia, gestational diabetes, and advanced maternal age co-occur and feed into one another, which drastically escalates a patient's risk. However, looking at the demographic breakdowns, we do see that these compounding risks are highly unequal. American Indian and Alaskan Native mothers, as well as Native Hawaiian and Pacific Islander mothers and Asian mothers, all face significantly higher baseline clinical risk profiles than other groups like white mothers and multi-race mothers. Furthermore, the data shows that younger demographics are disproportionately forced to rely on emergency departments for obstetric care, highlighting massive systemic gaps in planned proactive prenatal care. This brings me to one of the most important models in the project, the emergency room conditional probability model. I trained a categorical naive Bayes model on emergency department records to calculate the exact probability of a patient presenting with severe maternal morbidity, or SMM, based on where they seek care, their age, and their race. So using only those three factors, the model isolated a universal relative risk multiplier of 1.3 all the way to 1.5 for the South. So what this means in plain English is that simply seeking care in a highly restrictive policy environment like a southern state increases a patient's risk of facing a life-threatening crisis such as sepsis or severe hemorrhage by 33 to 35%, completely independent of their age or race. Looking at this comparative dashboard, we can see that, for example, a non-Hispanic white woman of average maternal age can expect a 2.45% probability of presenting with severe complication, but that exact same demographic in the South would have a 3.28% probability of a severe complication. So in this case, the geography itself acts as an independent medical risk factor. And again, remember that the geography is very closely tied to a state's actual legal policies about reproductive health care. Before concluding, I want to address what the data could not tell me. One thing I was really interested at the beginning was looking at specific Supreme Court decisions, including 1973 Roe versus Wade, 1992 Casey versus Planned Parenthood, and 2022 Jobs versus Jackson Women's Health, to see how those decisions directly changed infrastructure uses on a day-to-day level. Unfortunately, there are severe constraints to public available data that makes that impossible. There is a standard 2 to 3 year reporting lab for finalized federal health microdata, and the CDC heavily redacts state-level identifiers in modern public use birth files to protect patient privacy. Furthermore, tracking long-term clinical trends like medical network erosion or OB/GYN transition requires longitudinal data that is still unfolding. I'm constrained here by data availability, but the proxy metrics used do still point to a clear trajectory. To bring everything full circle, I want to talk about my neural network model. This network was tasked with classifying whether a state was restricted or not restricted using nothing but anonymous medical data and geographic region. It used 8 hidden ReLU nodes to then feed into an output sigmoid node that gave a probability of a state, or rather an individual record, coming from a restricted state or an unrestricted state. And this model's performance was an astounding 98.21% accuracy on unseen data, showing that the boundary between these two legal realities is vast and distinct. And the most important thing to keep in mind as we talk about this subject and wrap up the presentation is behind the numbers I've shown you today and these algorithms are deeply human consequences. When a vague legal ban conflicts with standard medical procedures, doctors may hesitate out of fear of criminal prosecution and turn treatable complications into fatal emergencies. Whether restrictive policies directly dismantle the healthcare infrastructure or signal a wider political underfunding of public health, the conclusion is absolute. A state's legal restrictions on reproductive rights translate directly into worse health outcomes and heightened mortality for its mothers. Thank you for your time. I hope you enjoyed.